It's hard for me to remember to push the red button since I was off for a whole week, which I really wasn't. I've been working pretty hard during the whole weeks we've been off. So your first lecture is going to be high risk and complications in obstetrics that include both laboring patient, postpartum patient, and the newborn. And to go over all of that, you'll notice in the objectives we have lots and lots of chapters to read. I suggest that you skim over them, and I'm going to try to hit most of the high spots on our PowerPoints, and I'll be putting your PowerPoints up in segments of which one PowerPoint, one recording, and I hopefully can get them all done very quickly for you guys. You don't have to listen to me forever and ever. So let's go to the um, PowerPoint. I think I need to clean my desktop off. Okay, so the first one we're going to talk about is the assessments risk factors. So let's get it up and going. Alright, so we're going to be talking about the high risk obstetrics, OB complications that we've already talked about. So first thing you really need to do is kind of review your fetal monitoring, be able to tell your variability, accelerations, types of decelerations, what complications you would expect to see, what type of deceleration. That's why we started looking at the fetal monitor. It's really not to just tell us what our fetal heart rate is and what our uterine contractions are. It's to help us assess fetal well-being and see how the fetus is tolerating the labor. So we have different types of risks that we're going to go and look at. Antepartum testing we're going to look at, and then some of the illnesses and complications that can cause intrautero, cause uteroplacental insufficiency. Okay, so our biophysical factors, there's biophysical factors, psychosocial risk, socio-demographic risk. And there is a page on page 638 in your book that lists those for you. You need to look at those and be able to, give me, be able to know what qualifies as genetic, what qualifies as psychosocial, um, even the demographics of low income, low prenatal care, uh, the age of your patient, if she's married or not, and of course your environmental service things are going to be doing that. So nutrition is a big thing with your biophysical factors. If you have a gravida patient come in who's well underweight, there's a nutrition problem there. She will need to have dietary consultations. She will need supplements. This is a very high risk situation for her, and she would need to be, um, gaining weight during her pregnancy because she doesn't have enough weight to support her own metabolism, let alone support the growth of a fetus. So this is something we really have to look at. And then, of course, on the other side of that will be your patients who are overweight and are at risk for having a bad situation happening there with their baby. And we don't normally see obese patients put on a diet, but they do encourage them to not gain a whole lot of weight. Uh, but they do still recommend that they gain the normal weight, but not gain more than normal weight. My little old cousin probably weighed 100 pounds soaking wet, gained 100 pounds during her pregnancy. And I don't know where she put it because her baby, when it was born, was like 6 pounds and 12 ounces and was long and skinny. So that was probably not very healthy for her. But She lost it all, thank God, she said. Of course, your medical and obstetrical disorders, those are all in your biophysical factors. And with your medical things that are going on, it can be some things such as pregnancy losses that put your patient at risk, complications of any obstetrical related illnesses such as preeclampsia, superimposed hypertension, and so forth. Some of the specific pregnancy problems are in box 26.2 on page 639. Your polyhydramnios can be caused by diabetes, fetal congenital anomalies, especially the gastrointestinal obstructions, and then your intrauterine growth restriction, anything that causes the placenta not to get the nourishment it should be, like hypertensive disorders, diabetes, renal disease, smoking, of course, even living at high altitude will cause them to have problems. And then you have the fetal placental causes, which would be chromosomal abnormalities, and such. And intrauterine infections are a bad thing. And then the oligohydramnios, which is a little water, a little bit of amniotic fluid, is, you know, considered a big marker for Potter syndrome, renal agenesis. Could be caused by premature rupture of membranes. Her water may have broken. She didn't realize that it was her water that broke. Thought she was peeing on herself all the time because it slowly leaked out. So there's a lot of things that we really have to keep in mind with that. Psychosocial risk are things that we can do something about, or actually the patient can do something about. So we can actually teach her about cessation of smoking and caffeine, alcohol, drugs, and what it does to the fetus as it's trying to grow. So these are things that we really can look out for. Smoking, we know it causes constriction of the vessels and causes intrauterine growth restriction, or causes it, I lost my train of thought. It can also cause miscarriage in the early trimester. Caffeine works basically the same way. Alcohol, you don't know if one drink at one party in your early 8 weeks of pregnancy will affect your baby or not. So we don't know, and it's immoral for us to do a test to figure it out. So no drinking is what we really want to advocate here. And of course, drugs, uh, legal or illegal, we need to take a look through there to see if they're affected by any of the drugs they may be taking. And of course, there's a lot of emotional distress that goes on with pregnancy, so we have to monitor our patient to see if anything's going on there, such as psychotic disturbances, addictive lifestyles, possible spousal abuse, cultural norms, and things like that. Then you have the socio-demographic factors. We usually can't change their income. We could probably help with the lack of prenatal care by having them go to a clinic or health department that provides that for them. But these are all things that puts the patient at high risk. So you need to know, when you're filling out your initial prenatal record, your patient first comes in to see you at the clinic, you're filling this out, and if you're marking more than one, you mark any of these, your patient is at risk, and the more you mark, the higher the risk. So their age is a big thing. Parity, how many babies have they birthed? If they're a gravid 8 and they've not birthed any, is she at risk? She's at high risk. There's some reason why she's not been able to carry a baby to term. If she's a gravid 8, para 9, then she's at high risk for possible preterm labor, postpartum hemorrhage, and things like that. Marital status, believe it or not, affects the well-being of the mother or the pregnant mother, because it gives her support and has someone that she can share this with, and she's not always emotionally stressed over it if she has someone who can help support her. Even residence has a whole lot to do with how their pregnancy goes. There are some people who are homeless. A lot of pregnant women are homeless, or they may live in a rural area where they don't get prenatal care and they're not able to go there. And then ethnicity, in itself is not a major risk, but some of the cultural practices that these groups use may cause the patient to be at risk. So you need to, make sure that we know what types of culture they're from. And then our environmental factors. These are things that various substances that moms meet in the environment they live in or work in. People who work in radiology are exposed to radiation. People who work in chemical plants are exposed to chemicals and pollutants. Infection, sometimes you may have what you think is a simple cold, and your baby may end up with cytomegalovirus, which is very deadly. So, I mean, these are things that can cause a lot of problems. Stress on the mom can help make her go into preterm labor, can also cause her to not do her diet quite like she should. And then paternal, is the dad totally supportive or is he not? So there are a lot of things in here that we need to look at. Even the paternal exposure to all these chemicals, radiations, and pollutants can cause their sperm to have defects in it and cause the baby to have some genetic disorder. So, one of the first things we want to look at is intrauterine growth restriction. The maternal causes that will cause your baby to have intrauterine growth restriction. Hypertensive disorders. We can see how that would affect the baby. You have hypertensive disorders. You had constrictive vessels. You have high. You have less nutrients going to the placenta. It takes a higher. It has a high resistance, which can cause things such as placental abruption. Diabetes, depending on how the diabetes, pregestational diabetes, can cause intrauterine growth restriction, because if their vessels are constricted and from having diabetes for quite some time and they're not controlled their blood sugar, the babies will be intrauterine growth restricted. Renal disease is chronic, or cyanotic heart disease. The mother's barely able to provide her own metabolism, let alone do babies' growth. Smoking, multiple gestations, and those high altitudes because you don't get enough oxygen in. Now, the fetoplacental causes, this is if it's based on fetus or the placenta, these issues can be chromosomal abnormalities, congenital deformities, intrauterine infection, which can happen quite a bit, like with herpes simplex or GBS positive moms, a genetic syndrome, or possibly an abnormal placental development, such as it develops too small, it develops the cord is too small, it develops across the cervix. Things like this can cause the different types of things that are going on. Okay. Pregnancy specific, I just went over that kind of briefly earlier, so I'm not going to read it to you again. Twin-to-twin transfusion is something I did not talk to you about. This is really fascinating. In that twin-to-twin transfusion usually occurs when they're sharing the same placenta or when two placentas actually merge together. But usually one of the vessels will feed one baby and then nothing will go to the other baby. So one twin grows really big and one twin is very small. And in the end, when they're delivered, if they live to be delivered, the baby that's the biggest has the most problems than the baby that's the smallest, because he has more fluid on his heart and in his lungs than what the twin that does not have. So they've actually come up with a laser surgery that they can go in and stop that major vessel from bypassing the twin by just causing it not to feed either one of them, and there'll be other vessels that will feed that. So I think that's pretty amazing that they can do that now. Used to before those twins would just die if they had twin-to-twin transfusions. Usually you'll see more than a pound difference in babies, and that's a lot. Okay, so let's talk about some antepartum testing. Why do we do antepartum testing? Well, we have to have a reason to do antepartum testing because not everybody that goes to see the OB doctor that's pregnant gets to have more than one ultrasound and or gets to be put on the fetal monitor to have their baby monitored. So some of the reasons that we will see the doctors doing these antepartum testings is you have post dates. So if they're over 42 weeks, and this is on the obstetrical side, these are things that are dealing with just the pregnancy. If they've had a previous stillbirth, we want to, and we don't know why they had that previous stillbirth, well, there's a good possibility that this one could be a stillbirth, so we want to keep a really close eye on that one. If we suspect that the baby is IUGR, there may be a reason for it. We had a doctor who suspected a patient was IUGR, and he monitored her with the fetal monitor, but if they'd have done a level 2 ultrasound, they would have found out she had a hypoplastic left heart, and definitely not prepared for the death of that baby. Decreased fetal movement. Anytime they complain about decreased fetal movement, it's an emergency situation. You want to get them in and put them on the monitor. And although we're kind of like, oh yeah, baby's just asleep, well, those 9 times out of 10 that it is just the baby's just asleep are wonderful. But that 1 time out of 10 when you can't find that fetal heart tone because mom didn't come in because the nurse kept telling her to drink fluids and lay on your side and do this and do that. If they don't feel fetal movement within for 12 hours and they don't feel it, or if they feel that's a big red flag. If they feel no fetal movement for 12 hours, they should have already been in. But if they have a very active baby that all of a sudden becomes very inactive, then that's another thing that we are going to be wanting to do some antepartum testing on. Anytime you have a mom that has preeclampsia, which is preeclampsia and gestational diabetes are both obstetrical situations, and you would want to monitor those. And of course, anytime that they don't have enough amniotic fluid, they can't develop their lungs, and they can possibly have some congenital deformities from that. So those are some reasons why we're doing that part. Medically, if we have a patient that comes in that has something medically wrong with them, then these are some reasons we want to do these. Diabetes, if they come in with pre-gestational diabetes, which means they had diabetes before they got pregnant, we need to monitor them very closely, especially with their glucose levels. So we need to monitor a lot about fetal growth and sugar supplies. Chronic hypertension works as kind of the same way as preeclampsia would, with that you can, baby's just not going to get enough of supplies to the placenta. Cyanotic cardiac disease is a big thing. We'll be learning more about cyanotic cardiac diseases later this semester. But if they have a cyanotic cardiac disease, that means they're not getting enough oxygen. If they're not getting enough oxygen, then the baby's not getting enough oxygen. Renal disease. If mom's having problems dispersing and getting rid of all her toxins in her body fluids, then the baby's going to have the same thing. And we'll talk more about thyroid and asthma, how that affects, and substance abuse later on when we get to those chapters. So you need to know about the biophysical assessment. Biophysical assessment includes your daily fetal movement, which is a kick count, or actually biophysical assessments do. And this is a great one to have mom to do. There's several different methods to do this. Personally, I like the 3 times a day thing, an hour for each time that you check. So that would be 3 hours, morning, noon, at night, to lay down for an hour and make sure the baby moves at least 5 to 6 times in that hour. Usually they move more than that. You can pick out a time where they're usually more active, so that's what happens. It's quick, it's easy, it's inexpensive. Mom can do this at home. Ultrasound, we can do vaginal or we can do abdominal. Vaginal ones are usually done for patients who are less than 14 weeks pregnant because their uterus is still down in the pelvic area and not where you can do an abdominal one. We want to make sure they have the right amount of amniotic fluid volume. Normal amount is 10 to 20, 25. 25 is a little on the high of normal. We want to make sure that we have plenty of fluid. We don't want too much and we don't want too little. We want a just right amount. Then your biophysical profile is a combination of several things that we'll talk about later. MRIs aren't done routinely on infants, but pregnant women, but they can be done. So just keep that in mind that, if you really needed to do something with soft tissue injury, you could do that. Okay, so we have biochemical assessments. These are where we're going to do assessments that involve an invasive procedure. The amniocentesis, we have to have the ultrasound used with the amniocentesis. So we want to be sure that we're doing that after the 14th week, because that's when your uterus becomes your abdominal organ. So this is just pulling out the amniotic fluid and has the fetal cells in it so that we can run tests. We can tell what gender it's going to be. We can have genetic markers that can say whether it's a Down syndrome, trisomy 18, things like that. Chorionic villus sampling, we've talked about a little bit earlier that you usually do this between 10 and 13 weeks. If you do it before then, you can cause some abnormalities in the infant's upper extremities. They'll have what they call flipper fins. The percutaneous umbilical blood sampling is not done routinely. You would be in a high risk area for that to be done. In order to do that, they will still have to use the ultrasound to make sure that they're going into the umbilical cord. It's also called chordocentesis, and you have to insert the needle directly into a fetal umbilical vessel, preferably the vein instead of the artery. The vein, of course, is what's providing the oxygen and stuff to the baby, and the arteries are what are bringing it back. But the cord's well anchored and it shouldn't move. But the only reason you would want to do that is make sure that they don't have any inherited blood disorders or fetal infection or possible thrombocytopenia. So you really want to make sure that there's a good reason to be doing this. Alpha fetoprotein is the one we talked about that they do at about 16 weeks. Usually around 16 weeks is the best time. 16 to 18 weeks are the ideal times. Alpha fetoprotein is if the alpha fetoprotein is high, then you are going to see what? If it's high, you may see neural tube defects. And of course, neural tube defects we give what for? Nice. We're going to make sure they're getting that vitamin B, right? So we're going to be sure that we are giving the folic acid, and we're going to measure it. And the alpha fetoprotein will tell us how much of the indication of whether or not there's a neural tube defect. If there's a low amount, usually what you're looking at is trisomy 21. So it can go either, you can use either way. So you can use it to figure out whether you got Down syndrome or whether you have a neural tube defect. So usually they're lower than normal, like I said, with the fetus with trisomy, and they're higher with one that has a neural tube defect. So they also have multiple marker screens that you can use. Um, there's a quad screen and there's a triple marker screen. Used to be just triple markers were all they use, but they now use the quad screen, and this is to increase the accuracy for screening for Downs in women that are older. Um, but none of these tests are, the alpha-fetoprotein, if it tests like they may have Down syndrome or they may have, that's not always going to be, that is not diagnostic. That is just telling you that there's a good possibility that this baby may have Down syndrome and requires further testing. Same thing with the neural tube defects. There can actually be another reason for this to be high, and so you have to have further testing for definite diagnosis with any of these. Of course, your Coombs test is going to be determining whether or not the baby has had some type of Rh incompatibility between maternal blood and fetal blood. So if the maternal titer for the Rh antibodies is greater than 1 to 8, we need to do an amniocentesis to check to see what the severity of the fetal hemolytic anemia is. So that's the reason we do Coombs test, but not every hospital does Coombs test. All right, and our electronic fetal monitoring, again, I encourage you to go back and look at those things. There's a box on page 649 that tells you indications for electronic fetal monitoring. There is no contraindications to do a non-stress test because it's non-invasive, but there might be some contraindications to do the contraction stress test, such as prematurity and ruptured membranes are some things that you don't want to do the non-stress test for. But you remember what the non-stress is. You have 2 accelerations within a 20-minute window that's 15 beats above the baseline that lasts for at least 15 seconds. That makes it a reactive non-stress test. If you have no accelerations, but you've got, say, some really great variability, but you don't have acceleration, that's going to be kind of indeterminate. But if you have one that has absolutely, variability is kind of minimum and there's no accelerations, then that is a non-reactive stress test. And what that means is they will have to go on to have a contraction stress test. A contraction stress test is where you put your patient on the monitor and you want to induce her into having contractions, and you'd like for contractions to be about every 3 minutes. For a period of time, and you can do this in one of 2 ways. You can start an IV and do oxytocin, start your Pitocin, or you can do nipple stimulation, which you can have the daddy help out with that one if you want, or you gotta have to teach the mom how to do the nipple stimulation stress test. Usually you give them warm, moist washcloths to put to their breast, and then they massage one nipple for 10 minutes and then massage the other one. So it's until they start having contractions. Why would that work? Because what happens when the nipples are tugged on, oxytocin is released because that's part of what helps the milk let down. So that's how come that works. So what about a contraction stress test? If we have a contraction stress test, what are we looking for? We're looking to see if the contractions that we have caused or that we have induced has any effect on the fetus. We're wanting to see if it stresses the baby out. Do my contractions stress my baby? Okay? So if she's having contractions and she starts having late decelerations after each contraction, that's known as a positive stress test. It's positive because we positively have stress from those contractions. It's negative if there's no effect on the fetus. It's a little different than the non-stress test. The non-reactive stress test is wonderful, and it's awful. And a reactive non-stress test is great. Whereas a contraction stress test, the positive is bad. So we really want to make sure that we understand what we're testing for. So what are we going to do? Well, the non-stress test led us to the contraction stress test, and if that has failed, then we go even further with testing, maybe doing the biophysical profile, doing several things of that nature. Now, the biophysical profile that we usually end up doing consists of doing the fetal amniotic fluid volume, which should be 10 to 25. Fetal breathing movements. We can actually see the baby breathing inside in the amniotic fluid. Fetal movement, which we can see through with the ultrasound, and fetal tone that's determined by the ultrasound. And then we have to have the fetal reactivity determined by our non-stress test. So those are all parts of your biophysical profile. So you really need to make sure that you are aware of what that is. Anytime that you're going to be doing fetal monitoring or amniocentesis, you want to be sure that you know what the contraindications are for them. Anytime you do an amniocentesis to someone who is Rh negative, you should be giving them RhoGAM afterwards, or at least checking to see if they need RhoGAM. Okay, so we can actually test through our amniocentesis. Back to that, because I forgot to tell you, we do check fetal maturity and fetal lung maturity through that. So our fetal lung maturity, we're going to be looking at surfactant. So we're going to be looking at the lecithin sphingomyelin ratio, which is should be 1 to 2. So we should be seeing those. I think that it tells you over on your, no, it doesn't tell you there. I thought maybe it would tell you there. Okay, we'll talk more about the LS ratio when we come to, well, actually it's in your fetal lung maturity section. And so we want to make sure that we know what they are. It should be 2 to 1. And that's 2 to 1. LS ratio of 2 to 1 means it's mature. But if you have a patient who's gestational diabetic or diabetic, it really should be 2 to 2. Because their lungs don't mature fast enough. Hemolytic diseases, we usually see that when mom's been Rh negative and she hadn't been given her RhoGAM like she should. So we already talked about indications for a non-stress test, or your high-risk patients that have preeclampsia, gestational diabetes, decreased fetal movement, those sort of things. The contraction stress test is done if you don't have a reactive non-stress test. And contraindications for those are basically going to be, if their water's broken or if they're premature. But there are no contraindications for a non-stress test. The only time you couldn't do a non-stress test on someone is if they are not far enough along as pregnancy. They need to be about 28 to 32 weeks before you can actually see the fetal monitor showing you any results that you can depend upon. So, some of the other things that the contraction stress test are contraindicated for was placenta previa, of course, cervical incompetence, if you've got someone who's pregnant with twins. They're all things that should be considered. I don't talk much about the vibroacoustic stimulation. That's just where you use a vibroacoustic stimulator to buzz the baby's belly, buzz mom's belly to see if you can elicit a response from the baby. And it's used if we can't get the accelerations to show up for our non-stress test, and sometimes it happens that we do. Okay. End of that show. Yay.